Thank you very much, Professor, and thank you to the Institute for inviting me. It's a great honour to be here. Conscientious objection is an important issue for all of us, but perhaps especially healthcare professionals. This is not because conscientious objection is necessarily required or felt to be required of healthcare professionals on a daily basis. On the contrary, for many healthcare professionals, depending on their area of work, the choice to exercise conscientious objection may be not unreasonably quite rare. Nonetheless, all healthcare professionals should be prepared to exercise conscientious objection in some circumstances for at least two reasons. The first reason is that conscientiousness is a virtue, and healthcare professionals should be conscientious people. If they think complying with some demand involves wrongdoing, for example unjustified harm to patients, then naturally they should be prepared to refuse. Healthcare professionals need the virtue of conscientiousness, and as patients we need healthcare professionals to be conscientious, even if this sometimes means we are frustrated in receiving at least immediately what we demand. Healthcare professionals should be not only trusted but trustworthy. They should be people of integrity. To say that someone is conscientious is not, of course, to say they are always right in the judgment grounding their refusal. Healthcare professionals are not morally infallible, not least as they must sometimes make difficult judgment calls. For example, on whether some high-risk form of surgery is too high risk to be rightly performed on this patient here and now. However, they should not do something they believe, however mistakenly, to be wrong or wrong in this situation. Indeed, so important is moral integrity that they should be prepared to suffer any consequence rather than do what they think is wrong. Note that it is not so much the moral distress to healthcare providers in doing what they think is wrong that is at issue, though this is also important, but rather the violation of conscience itself and the moral harm that involves. It might be asked how the negative moral duty not to act against one's conscience squares with the positive moral duty to act as requested, which may be present, for example, to perform emergency surgery that may be risky, but not too risky to perform. While there may be a general moral duty in some situations to act, and even to act immediately in some emergencies, this general moral duty is a duty to act in good conscience and not in bad conscience. Just as the general duty to do the emergency surgery does not apply if the surgeon is having problems with his or her eyesight, this general moral duty does not apply if the surgeon is currently unable to see the surgery as morally justified. Occasionally, a doctor or nurse may need to be penalised for a morally mistaken, albeit sincere, refusal. However, such is the value we should place on moral integrity that sympathetic accommodation should often be extended to cases where we believe the objection is not, in fact, well-grounded. The second reason conscientious objection is important is, however, my main focus today. My focus is cases of conscientious objection which are justified in a deeper way because the requested practice goes against the values of medicine and of the healthcare professions more generally. By this I mean not merely that the practice is extra-medical. A doctor who straightens a crooked nose is not engaged in medicine precisely, but that the practice is anti-medical. It ends life deliberately, for example, or sterilises a patient for reasons of family planning, or it takes reckless risks in the course of medical research. Medicine exists to serve health and deal with the effects of pathology, including in those who cannot be cured. It is true that doctors have always been asked to do other things as well, and have often obliged. That includes some practices which, even if permissible, do not involve their acting as doctors. Plastic surgery would be a modern-day example. Doctors have also been asked to do things which fall outside their remit in a stronger sense. These are things no doctor should be asked to do, as, for example, they cause unjustified harm to health, the core good the medical profession exists to serve. Many doctors have pushed back against such demands, as the Hippocratic Oath bears witness, but also personal stories of countless medical practitioners down the years. It is not for the state or even professional regulators to be the sole source of ethical guidance for the healthcare professions. The historical moral failures of medicine, as two researchers have put it, give us ample reason for rejecting such a simplistic notion. Rather, each individual doctor, nurse or pharmacist, for example, should seek to practice authentic healthcare, or at very least to respect people's health, even when health is not being, or can no longer be, significantly promoted. Palliation in particular does not merely respect health if properly practiced, but constitutes authentic healthcare. To cease from burdensome or futile attempts to prolong life and focus instead on palliation to address the effects of disease is not at all the same as deliberately attacking life and health in the person who cannot be cured. It may be replied that it is patient wishes and or patient satisfaction to which the doctor should respond. The doctor will benefit the patient, if only by respecting the patient's autonomy, in agreeing to perform elective, function-destroying or life-ending interventions. However, just as there are moral limits to what patients should be asking, bearing in mind their need to respect their own health, there are limits to what doctors should be providing. Life and health have their own ethical demands when doctors assess the burdens and benefits of treatment. Health benefits cannot simply be replaced with other potential benefits, such as social or aesthetic benefits, even assuming the latter benefits will indeed be promoted by intervening. We no longer castrate boys to promote their singing prowess, with or without their own request. Nor can we defend ourselves from criticism with regard to health-impairing acts by pointing to future threats to health we may be preventing if those future threats are only socially, arbitrarily prevented by the impairment we cause. Otherwise, we could, for example, amputate toes so that men will not be sent to war, or sterilise women to protect them from partners who threaten violence should they ever get pregnant again. These interventions may be aimed at protecting future health in some sense, but we cannot call them healthcare. True, the demarcation between the medical and the non-medical can sometimes be difficult to draw. In the case of neurological and psychological conditions, emotional distress of some kind may be the very internal pathology we are trying to address. It is too quick to assume that physical solutions may never be sought for emotional distress, which of course leaves its own physical trail. But in any case, the difficulties and complexities of this area should make provision for conscientious objection more generous, not less. There may be a range of objections to some interventions with regard to emotional distress. With the gender dysphoria, for example, some doctors will be unwilling to provide surgery and or hormones for adults or children experiencing dysphoria, as they believe other solutions should be sought for the very real feelings the patient is experiencing. Others will point to the lack of high-quality research supporting a long-term beneficial effect for hormones or surgery, while still others have concerns related to the special nature of reproductive functioning in particular. Such functioning, they may argue, is not just any bodily function, but one with transcendent value and meaning, such as that there is a particular objection to performing sterilising or similar procedures on people in a quest for psychological peace. Then there are situations where the aim of a procedure is not so much to benefit the subject of the procedure, him or herself, but someone else entirely. Where significant harm will be caused to the subject of the procedure, as opposed to harm from which the subject will recover, as with some forms of organ or tissue donation, this should cause serious concern. Even if harm is not intended qua harm, the doctor will sometimes be rightly unwilling to inflict it, particularly if the harmed subject's body is directly intervened on to benefit someone else. For example, a doctor may decline to separate conjoined twins, or to separate them by invading a part the twins share, on the grounds that this causes grave harm to one patient's body via an intervention on that body in the course of helping another patient. The operation may be health promoting for one twin, but may lethally maim the twin whose body part he or she shares. Such cases suggest that when we frame permissions for conscientious objection, we should not be too quick to exclude cases of emergency or life-saving surgery. Not all life-saving procedures can be justified, let alone required, if the immediate focus is on the body of a harmed human being. If a doctor, for example, is unable for ethical reasons to participate in some practice, what should he or she be expected to do? Referral to a willing practitioner is sometimes proposed as the alternative, but this shows a shallow perception of the logic of conscientious objection, at least in many cases. If the doctor believes that the requested drug or procedure will be harmful to the patient, for example, and is unwilling to provide it on those grounds, will not the doctor similarly be unwilling to arrange for the patient to obtain the harmful drug or procedure elsewhere? What kind of message does that arrangement send out, and what kind of concern does it show for the patient's welfare? Moreover, there is a subtler objection some doctors may be aware of to referring or signposting the patient to another doctor. Even if the doctor knows the patient will obtain what they want in any case, or alternatively knows that the other doctor will also refuse, there is an objection to intending the patient's immediate revised plan to obtain the drug or procedure from another doctor. That is because if the proposed intervention is indeed morally wrong, even if the patient is in good faith in requesting it, then all plans, including immediate plans for the procedure, will also be morally wrong and should not be deliberately invited. The conscientious objector may in practice need to make some general reference to the right to a second opinion from someone, unspecified, to cover him or herself, and defuse the situation while offering positive alternatives. However, nothing he or she says should involve the intention that the patient now plan to get the wrongful intervention elsewhere, or that a colleague start helping the patient with this plan. The first doctor's motive may be good, to avoid the patient experiencing distress and possibly making a complaint, but on an intention-sensitive view of ethics, all our intentions, not just our further intentions, count when it comes to judging an action morally. Planning to do something wrong, however unsuccessfully and however much in good faith, is itself morally wrong, and someone's forming such a plan is thus wrong for another person to intend. In technical terms, this is formal cooperation in wrongdoing, sharing or otherwise intending someone else's wrongful intention. Traditionally, and I believe rightly, such formal cooperation, unlike material, unintended cooperation, has been seen as absolutely morally excluded. Finally, it is worth remembering that healthcare professionals cannot be expected to foresee all the moral objections they may develop in the course of their work. Sometimes they are confronted with a situation in a visceral way, which can lead to conscientious objection after the healthcare professional has already been personally involved in the practice to which they object. Dr Richard Lyas, a UK gynaecologist who himself performs late-term abortions, stresses that abortion doctors too can have qualms of conscience. Abortion providers, he says, do not fall neatly into groups of providers and objectors, and ambivalence is a key theme in their experience. In particular, it is unfair, he says, to expect developed views on these issues from medical students or would-be medical students with insufficient experience of them. Lyas criticises a biological stance that, as he puts it, demands individuals devolve moral decision-making to a forum separate from that in which the moral act takes place. This forum might be at the level of managers, regulatory bodies, or philosophical discourse, for example. When very serious questions of violence and destruction of life are concerned, I find, he says, this proposal concerning. Such a way of practicing could become profoundly alienating for the doctor, for it requires that he or she work in a moral vacuum, maintaining a perfect neutrality, he says, in the face of killing. The academic lawyer Mary Neal comments that forcing healthcare professionals to compartmentalise their moral commitments and live parallel professional and personal moral lives, in which they apply contradictory sets of values, is liable to undermine and erode agent integrity. In contrast, she goes on to say, accommodating conscientious objection provides space within which the individual can develop and maintain her identity as a moral agent, and it protects the coherent functioning of her agency by shielding her from forced violations of conscience that sever the link between conscientious reflection and conscientious action. An interest in acting conscientiously, understood as an interest in achieving and maintaining one's moral agency, cannot be regarded merely as one more interest to be weighed in the balance. To conclude, health is an objective human value, and healthcare professionals should be guided by that value, which is, after all, the raison d'etre for their professions. Nor is this about putting the healthcare professional's interests before the patient's. The professional may be rather thinking precisely of how best to respect the patient and everyone else involved. Nonetheless, even if personal moral integrity is not the healthcare professional's conscious focus in his or her conscientious objection, such integrity is also a genuine value that demands respect, like the value of health itself. We should trust healthcare professionals not to obey us blindly as patients, as if our health had no moral claims on us or on them, but rather to offer interventions they themselves believe respect health, and are such as they can offer with peace of mind. Thank you.